Good morning, everybody, and welcome to Treasurer Folwell's first Ask Me Anything of 2021. We hope you're having a very happy new year so far. Treasurer Folwell is here, and he would like to make some opening remarks, and then after that, we'll open up the floor for any questions you may have. Just make sure your phone is muted so we can avoid any interferences. But with that, Treasurer, take it away.
Thank you, Lindsay. Thank all of you for joining us. Happy New Year, and just look forward to all of your questions. From the media alert yesterday, we have some preliminary numbers regarding the performance of the pension plan. The plan ended the year preliminarily at about $115 billion, obviously the highest level in the history of the state, and we're looking at preliminary performance numbers north of 10% for the calendar year. So I'm reporting that to you and standing on the shoulders of the hardworking folks in the investment management team who have shepherded this plan through a very volatile time since this time last year. So we appreciate you all joining us and be glad to take a question on any matter that you'd like to ask about.
All right, first question, just go ahead and say your name, who you're with, and ask away. Anyone have a question?
Even if you don't have a question, can you chime in just to see if you can hear us?
Hi, good morning. This is Diane. I can hear you fine.
Hey, how are you?
I'm doing fine, thank you.
Good.
Do you have any questions for Treasurer Folwell?
Yeah, sure. I wanted to know, I understand the correlation between, this particular rule and wanting it to be implemented. My question is, overall, I know that patients, North Carolinians who have any medical issues or in any time see a doctor will be impacted on what this policy is, will be positive. I just wanted to know, how do you foresee it impacting the state health plan?
Thank you for your question. This is obviously not a giant step, but it's a baby step toward something we've been working on for nearly 3 years, which is transparency and clear pricing for the state health plan, which we think positively affects all North Carolina citizens, not just ours, but our focus is on the state health plan. We think that any time that you get rid of secret contracts and push the power to the consumer, that ultimately it will increase access to health care, it will increase affordability of health care, and ultimately it will increase the quality of health care for those that teach, protect, and otherwise serve. So as I said earlier, it's not a giant step, but it is a baby step in the right direction. I would add to that, which you've heard me say before, there would be an economic gold rush in North Carolina if we were known as the state with transparent health care. You've read recently about the collapse of the joint venture between Warren Buffett's Berkshire Hathaway, Jamie Dimon's JP Morgan, and Jeff Bezos' Amazon, as they tried to come together and break the cartelization of healthcare across the country. What you may have heard me say, but may have forgotten, is the fact that the state health plan, the number of members in this state health plan is almost equal to the U.S. employment base of Berkshire Hathaway, JP Morgan, and Amazon combined. So even though their project is no longer going forward, based on the economics and the buying power of the state health plan, we're still in the game. And as I've said before, anyone who's in favor of secret contracts and surprise billing and split billing in healthcare is ultimately going to be on the wrong side of history.
Thank you.
Do you have any follow-ups, or if not, we'll take any other questions?
Hi, Dale. This is Dave Mildenberg down in Charlotte. Hope you're well.
I'm doing great, thanks.
Hey, Dale, January 1, the switch on if you're a new state employee, you don't get health benefits. You were just carrying out action that was taken in 2017 by the state legislature, as I understand it.
Yeah, let me correct. You obviously get health care benefits while you're an employee of the state, but not just in post-retirement.
Excuse me, absolutely.
Yeah.
Post-retirement health care benefits.
Right.
So if I get hired today, and obviously there's not a lot of hiring going on in the state government right now, but in 10, 20, 30 years, then I may not get benefits.
Right.
So the actual impact of this, do you see it being significant in the next decade? And two, I know it wasn't your decision. Do you have a personal opinion on the wisdom of that change?
Well, thank you for the question, Dave. And being from Charlotte, you are very aware of the fact that the city of Charlotte, as well as the county of Mecklenburg, made this very change over 12 years ago. And so really the state of North Carolina is following suit. And the state of Virginia made this change decades ago, as well as most of our border states. So what I would say is what I've said in the past is that we had no knowledge. We have had no conversations back in 2017. I got a call. It showed up in a conference report that this change was part of the budget, but the effective date was several years out to give the system an opportunity to get ready for it. So our total involvement has been following the law as passed and getting our IT system in place to create the tier. Secondly, as far as the fiscal note, I don't remember what the fiscal note says. I do know what the CAFR says today, and that is that even though we've had a dramatic decrease in our unfunded healthcare liabilities, especially over the last year, they're still at $28 billion. And it's my belief when the new Pew Research study comes out, it will show that we are still one of the top handful of insolvent healthcare plans in the United States. The last Pew Research that came out showed that on a per capita basis that our state health plan insolvency was right behind the state of Illinois. That's right, the state of Illinois, not the pension plan, but the health plan. As the savings will probably be eaten up by the hyperinflationary cost of healthcare in Charlotte and other parts of North Carolina going up at a far faster pace than inflation, and that's why the clear pricing project that we talked about with the previous reporter is so vitally important. That's the ultimate long-term solution. As far as how I think about this, this is an issue. Our unfunded liabilities are obviously a big topic of discussion when it comes to the rating agencies. As we sit here today, we have 14 states that still maintain, I believe, a AAA bond rating. I would like for all states to have that, but the fact is that this time next year there are going to be less states, not more states with AAA bond ratings, in my opinion. And a large part of our conversation with the rating agencies, since I've been the state treasurer and keeper of the public purse, is how are we dealing with the unfunded liabilities? There's a term that all of us have heard for most of our lives called II. We hear it, but not a lot of people know exactly what it means. II means I hear you, I understand what you're telling me, and I intend to do something about it. And the rating agencies, especially when they look at North Carolina, which has such a stellar rating and such a conservative budgeting practices and such a strong pension plan, they want some level of about that we understand these unfunded liabilities. We hear them, we understand them, and we're doing something about it. My solution for doing something about it was to continue to get rid of secret contracts and push the power to the consumer and lower healthcare costs that way. But just to be clear that because we sort of nuanced this in the beginning of your question, active employees this year for the 70-30 plan are paying $25 a month. We have frozen that rate for 3 years, even in light of not getting fully appropriated for the inflationary cost of healthcare. We have frozen family premiums now for 4 years. But just because I can afford something or freeze the cost of something doesn't mean I can afford it, and then it also doesn't mean I can get sick. Just because I freeze the price of a Maserati doesn't mean I can afford it, and if I could afford it, it doesn't mean that I can maintain it. So what we're driving toward here is going back to the BBA, which is Bezos, Buffett, and Jamie Dimon. What we're driving for is to ultimately reduce family premiums so that we can attract younger, healthier people in the plan to offset folks like myself. So that was a very long explanation. You're always honoring to listen to all that, but it's all connected and it's all vitally important. And what our goal is and remains is to continue to get the pension plan and the state health plan fully funded each and every year, not just 10 or 20 years from now. So the savings on this will start out as a very small tail. It'll be almost, you won't be able to see it on a piece of paper, but it will ultimately grow. But as I said earlier, the city of Charlotte recognized they couldn't do this over a decade ago. The county of Mecklenburg, many counties and cities across North Carolina, the state of Virginia. The state of Virginia, Dave, for example, if my memory is correct, when you retire after 30 years of service in the state of Virginia, you get $4 per month for every year of service.
Uh-huh.
So that's, if you're 30 years, that's $120 a month. You can buy cigarettes, lottery tickets, or you can go buy a health care plan. And so that's why when you look at these statewide numbers across the southeast United States, you say, why does Virginia have an OPEB liability? And the answer is mathematical, because they don't have this tail. So that was a long answer to your short question. Go ahead.
Well, if I could follow up, that's very helpful, because myself and others who've written about this, I don't recall them including that information about Virginia and the local municipalities making the similar move, a long time ago. If you have $120, it's a good time to go buy that lottery ticket, by the way, right now because of the Mega Million, right? But seriously, do you know about Virginia? Do you know about South Carolina and Tennessee? Do you happen to know off the top of your head if they,
I really pride myself about top of the head statistics, and so I'm going to preface this by saying it's about 5 years old in my mind. See, every active and retired employee in the state of South Carolina has been paying probably in excess of $80 a month for health care while they worked and in retirement. So
right.
South Carolina does not have the same. South Carolina has not a surplus, but South Carolina has a situation where they have built up a reserve to offer this benefit. In the state of Tennessee, if my memory is correct, every active and non-active employee pays $89 per month. And see, our premium for almost 45 years was zero. So,
yes.
And so what Tennessee and South Carolina has done, and my memory is correct, and we can follow up on this through email, is that they've been charging between $75 and $100 per month for health care every month while that person was working, and they've been carving off part of that toward a reserve toward their liability for these folks in retirement. Now, the second thing I will add to that is going back to the state of the county of Mecklenburg and the city of Charlotte, is that if my memory's right, they have nearly $1 billion of OPEB liability, even though they stopped this over a decade ago.
Yeah.
Combined liability. And to their credit, the City Council of Charlotte and to some respect the County Commission of Mecklenburg, I think the City of Council has over $100 million sitting in OPEB reserve to put toward their unfunded liability. The City of Winston-Salem under Lois Coakley started this 34 years ago. The City of Winston-Salem has an $86 million liability, but they have $60 million sitting in reserve. So the City of Winston-Salem has an OPEB liability, but they've paid this, they've basically almost completely defeased it because of choices. These are choices that city councils make and county commissions make to put money toward this. Just imagine where our unfunded liability would be right now if we had just taken $20 a month per member per month 40 years ago. We wouldn't be in the situation we are today. And when you look at what's happening, and I'm going to throw this in, when you look at what's happening with the annual required contribution of the pension plan as a percentage of payroll, this year in North Carolina that we're getting ready to submit, it's going to be nearly 16% of payroll. So if you look at the slope of that line, as far as the pension contribution, I'm sure that's why the General Assembly took the action that they did, but you would have to ask them that question.
Hey, could I follow up with one other question? As you referred to the freezing family premiums for, I think you said 3 or 4 years?
4 years.
And for single employees for 3 years?
Yes, at $25.
So, and you understand how the system works, because I think a lot of private sector businesses would not have had that same experience over the last 4 years. So, I mean, would you agree that those hundreds of thousands of employees that you represent have the cost has shifted to others?
No. We were able to do that and slightly build reserves, even though we've been under-appropriated from the General Assembly during some of that period of time. We've been able to do that because of internal savings within our own plan that doesn't affect anybody outside this plan.
Really? Okay.
So for example, as you very well know, we just negotiated a fantastic contract for our baked in for 5 years with options, where our post-65 retirees, which I'm approaching that age, the post-65 retirees, no premium to them and no cost to the state. And that one contract is going to save $1 billion over 5 years. That's $186 million a year. That's pure money, cash on cash savings. And that and other incredible efficiencies that we've driven through the state health plan has given us the cushion that we've needed to freeze these premiums. And
well, 168 million, 186 million savings for the state health plan.
Yeah, just from the Medicare Advantage contract.
Right.
And
but I guess my question though, is if assuming it's company United X or Blue X or whoever it is, aren't they just gonna, they still need to make a margin? Aren't they just shifting that to other people?
Well, that's
you understand this stuff more than I do. I just wondered if that's the way it works.
I try not to use this word, and I do it elegantly. That would be incorrect. The reason that we were able to do this is that, as you know, the Medicare Advantage product is highly subsidized by the federal government.
Okay.
So when we throw a book of business of 150,000 lives, that's a lot of lives in the Medicare Advantage space. When that book of business, wherever it happens to rest, with any of the people who submitted bids on that business, wherever that happens to rest, that gives them the buying power, and there's a star rating based on quality that gives them higher reimbursements from the federal government. So I'm 100% certain that whether it's freezing family premiums or freezing individual premiums or the fantastic renegotiation on the Medicare Advantage product, that it had zero impact of shifting or cross-subsidizing or costing anybody else in the state one more penny.
Okay. Well, thank you for that explanation. Appreciate it a lot.
Yeah.
This is not Center Square, and I did have a follow-up question about the. Can you hear me?
Barely. You're muffled, but continue.
Okay, sorry about that. The Claire pricing project. So, what has been the impact when it comes to cost reduction from the Claire pricing project on the state health plan?
Good question. We are still analyzing cost reductions, but in some respects, it's that term that all of us have heard all of our lives, but we can't quite get our arms around it, and that is you can't prove a negative. The clear pricing project was meant to financially exalt primary care physicians and mental health specialists, which we think are closest to the health and well-being of our citizenry than any other practitioner there is out there. And in the process because we didn't know what these folks were making, and we quickly realized when we actually started getting a hold of some of our data, not to the extent that I'm satisfied with, but because of the state laws that prevent us from actually getting our own data in some ways that we actually can use it, we realized that the mental health specialists and the primary care physicians, who I consider to be general contractors, we're not getting fairly compensated. So there has been a cost associated with paying those individuals more money. But these individuals at the primary care and the mental health side, they can control healthcare costs. They know if you actually need a plumber or a carpenter or electrician, which is how I characterize what happens in our body, carpentry being bones and joints, and electrical being neurological, and plumbing being vascular. So it's hard to figure out, but we're continue to work on what the savings will be. But more importantly, it really goes back to Dave's question. Because of the efficiencies that we've driven through the state health plan and our ability to slightly build reserves, even in light of not being fully appropriated by the General Assembly, which we're working on. Even in light of that, we still are able to carve out some cushions to make these kinds of investments. We just know that any time that a primary care physician or mental health specialist, as a general contractor, has to refer somebody into these large hospital systems, and then the cost and the test get out of control.
Thank you. And then so a follow-up question in regards to the health cost transparency rule or policy that you're pushing for at this time. Now, the Hospital Association, they are arguing that it doesn't really reduce the cost for patients. They're still going to pay the same thing for treatment. What is your response to that?
Can you clarify that just a little bit?
Okay, so I have an article here where the American Hospital Association, they're saying that disclosing the rates, like the contracts, the information that they have, the pricing between them and hospitals, between hospitals and the insurers, wouldn't really make an impact or wouldn't change the pricing because patients still would have to pay for treatment anyhow.
I have found the responses that I've heard from the Hospital Association to be nothing but bizarre. They're mathematically bizarre, and they're commonsensically bizarre. It just doesn't make sense that if you don't, if you get rid of secret contracts and surprise billing, and you push the power to the consumer, like has happened in 80% of everything that all of us spend on a daily basis in all aspects of our lives, how you're not going to get more access and lower cost. It just, how can something be working for 80% of our consumer spend? That's everybody on this call and everybody sitting in this room. How can that be true for 80% of everything we do and not be true for this? And the fact is that many of these institutions are for-profit when it's to their advantage, and they're non-profit when it's to their advantage. I mean, some of these major medical centers are hedge funds and money management firms as much as they are deliverers of hospital services. We just think that there is a better way of bringing people together that benefits those that teach, protect, and otherwise serve, which is our responsibility. That would, when you decrease the cost of something, you increase the access to something. It's hundreds of thousands of years of economic theory. You reduce the cost of something, you're going to increase the access to something. And we think that when people have these tools, that they ultimately will not only just have lower cost and more access, then they'll be able to be more discriminate about the quality of the health care that they're receiving. So, as I said earlier, anyone who continues to be in favor, like the Hospital Association, of secret contracts and surprise billing is going to be on the wrong side of history.
Do you know of any examples of scenarios where they were secret contracts, or they are the contracts between the insurers and the hospitals created a wide margin of profit for them that you can share with them?
Well, that'd be great, except when I asked for the master charge list from UNC Healthcare, which is owned by the taxpayers of this state, they sent me 158 pages that were completely redacted.
Oh, wow. Okay.
So we know, and there's should be some videos on YouTube with me showing that, but we know what we're paying. We just don't know what we're getting. As many on this call know, I went through my own intensive battle nearly a year ago with COVID-19 that resulted in the ICU stay. I'm not telling you anything I don't want you to know. Several years ago, I had my gallbladder removed. I mean, when you look at the explanation of benefit, for example, of those two treatments, you can't tell if I had COVID or had my gallbladder removed. I mean, people, it's impossible. And I've had leading hospital administrators in this state, when I ask them about when they need medical attention and they get an explanation of benefit, they say they never even open the envelope because they don't understand them. These are the people who have the responsibility of administering these programs. Just imagine the impact it's having on all North Carolinians, especially lower and fixed income individuals. And I will tell you, as a person who spent a third of his life in that world, one surprise medical bill can blow a person up as far as their upward mobility in life, because that manifests itself into a bad credit, that manifests itself into paying more for automobile insurance, paying more for cable, paying more for student loans, paying more maybe for a mortgage. One surprise medical bill can really end a person's, for generations, can end their upward mobility.
Thank you, Treasurer Folwell, for that and for your response. And definitely that definitely shows the human impact of surprise billing and high healthcare costs. I appreciate it.
Thank you. And most people are obviously, they know what the word surprise means. They know what billing means. And what it means in this context is when you, and it's not always an ER situation, but mostly it is, when you go into a hospital and you're in need of medical attention very quickly, you have no way of knowing that some specialist who may be working on you are, quote, out of network. I mean, even though the hospital's in network, and 97% of the people in the hospital are in network, but that person who may be attending to you is out of network. And that's when you get these huge bills and you get put in this financial vortex, which unfortunately most people never get out of. And so when I use this term, on the wrong side of history, it's not just about something you read in a book. It's about the generational lid that it puts on people. And in my estimation, it perpetuates poverty. I don't know how in the hell any public servant or leader in this country would be in favor of anything that perpetuates poverty.
Do you have any other questions for Treasurer Folwell?
I'm sorry. Yes, I do. I apologize, and this might be a dumb question, but I like clarity. So at this time, you're pushing for this rule to be implemented. So just to confirm, you are calling on lawmakers then, because they would have to implement this, or what would be the next step? It's a real question.
I'm not as familiar with the rulemaking process at the federal government, but if it's similar to the state government, it would not involve a legislative body. The rulemaking of North Carolina goes through Office of Administrative Hearings, and I'm sure there's some equivalent at the federal level that rulemaking comes a part of. But as I've tried to communicate both with my mind and my stomach and my heart this morning, you don't need a law to tell you what's right and what's wrong. And as former Governor Martin always admonishes us of North Carolina, doing right's rarely wrong. And, doing the right thing would be to voluntarily get rid of secret contracts and be willing to push the power to the consumer. And you don't need a legislative body to do that.
Thank you.
Thank you.
All right, if there are no further questions, I'll let Treasurer Folwell make his closing remarks, and we will see you all next month.
Thank you all for joining us. I've been asked several times over the last 2 weeks about our goals for the next year, and our goals remain unchanged: loyalty to those that teach, protect, and serve, and exercising a duty of care regarding the things that we have responsibility for. Our additional goal that we have been concerned about for 3 years, but especially just in the last year, is the lack of flattening of the economic curve for many of our citizens who make their living with their hands, their back, and their feet, and even our essential workers who do work for the state. As Dave and others know, just in the last 10 days, we've lost a warden and an assistant warden at the same corrections facility in North Carolina to COVID. Our lack of monastically focusing on the nursing homes, the hospitals, and the correction facilities of this state almost a year ago is turning deadly, and we have to approach this with transparency, with consistency, and with the willingness to challenge assumptions in open meetings, so that in a way that people don't get their feelings hurt. Because I can tell you that there's a lot of feelings hurt right now from the families of those that this warden and this assistant warden of the same facility in North Carolina who died in the last 8 days due to COVID-19. I don't say this with any amount of glee. The prisoners aren't leaving the building every day. It's the workers. So when you have these big breakouts across North Carolina in the corrections facilities, as hard as those people are working, then these employees go home every day. And that's why we have been in favor of monastically focusing over the last 10 months on correction facilities, nursing homes, as well as hospital essential workers. And this is anecdotal. It's y'all's job to look into this, but the issue about how we attack this problem is very important, and whether it's regarding the vaccine or testing, we have to do something, because, as you've read in the Wall Street Journal over the last 3 weeks, people's confidence in government, unlike in some parts of the world, in this country, is not going up, it's actually going down. And it's going down for reasons that we can address. And we need to get on about the business of addressing them.
All right, thank you so much. We will look forward to hearing from you next month.
Thank you all.
Bye, thank you.